Okay, great. So we're just going to go over like some general tricky stuff from previous terms. And once again, if as we're going, there's any specific questions, let me know, and we can go over like specific modules in more depth. I know, especially module 3, since we didn't get to do that one all together. Okay, so let's get this started here. I'm going to start with module 3 just because it was the most recent one and also the one we didn't get to do. So in terms of things to know from module 3, so it's cardiovascular and pulmonary. There are more questions about cardiovascular stuff, and I personally find the pulmonary material to be a little bit more straightforward. I think that's because we've heard of things like asthma more frequently, like you probably know someone who has asthma. So I just find it to be a little bit easier to understand. So if you feel like you're wondering what to focus on for module 3, I would definitely focus on heart failure and myocardial infarction versus angina. Essentially, those 2 chapters are much more heavily represented on the midterm. In terms of the pulmonary stuff that you need to know, you should know for chronic obstructive pulmonary disease that there are 2 types of that essentially. There's one that's like due to emphysema, and then there's one that's due more to like bronchitis. So just knowing the differences, and that's really it. You should know that emphysema is essentially like the lungs lose elasticity. So they have what's called a lack of recoil. So your lungs should inflate and then deflate naturally. And in emphysema, because of the loss of elasticity, they can inflate, but then they kind of like don't have that recoil. They don't tend to deflate as much. So let's see what else. Oh, you should know this was your discussion for last week. The patient, spoiler alert, if you haven't done it yet, which hopefully everyone has, but the patient has a pneumothorax, which is a collapsed lung. One of the key signs or symptoms of pneumothorax is you have lack of breath sounds on one side, because usually, hopefully, you only have one lung collapse. You can have like a partial pneumothorax, so it's possible. But so if only one lung is not working, then obviously you won't hear breath sounds on that side. So that's a pretty classic pneumothorax sign or symptom. And some other things we'll go over together, just some differences between things like bronchitis and asthma. Once again, I think those are a little bit more straightforward. In terms of the heart stuff, signs and symptoms of heart failure are a big one. Like I said, there are a lot of signs and symptoms for heart failure, and I think that's why going through some of the reasoning behind that can be helpful, because it can help you organize your thoughts as opposed to just like brute force memorizing everything, because there are a lot of them. So some of the key things to remember, of course, are like the flow of blood through the circulation. And then that forward effects, those cause decreased perfusion, meaning those target organs are not getting enough blood. So the target organs are not going to work properly. And then backwards effects, those are all due to swelling or edema. And that's because of increased hydrostatic pressure. So essentially, fluid gets built up in different places. And when we say forward and backwards, that has to do with the blood flow through the body. So a backward effect is backwards from the part of the heart that is affected. So for example, for the right side of the heart, what is backward from the right side of the heart is the rest of the body. So we will see fluid build up in like the jugular vein or the vena cava, so the veins, because that's before you get to the heart rate, so it's backwards. Fluid build up in the liver, that would be hepatomegaly. Ascites, that's fluid within the abdomen. So all of those things, so essentially swelling, fluid throughout the body, those are classic right side backward effects. Left side backward effects, what's backward from the left side of the heart? The lungs. So you will see fluid in the lungs. In general, thinking about forward and backward effects are usually more severe than forward effects. So oftentimes when you are thinking about heart failure signs and symptoms, most of the time we're actually talking about backward effects more so than forward effects. And then for the midterm, all of the questions are straightforward. There won't be any like trick questions. But in reality, most people don't just have like left side heart failure. They usually have aspects of both. So real patients will almost always have signs and symptoms of both right and left heart failure. But on the midterm, if you see someone who has, for example, like a heart failure patient with ascites, that's right heart failure. We're not trying to like trick you or anything like that. Okay, so let's go through those specific signs and symptoms you need to know. So these are all signs and symptoms of backwards effects of heart failure that you need to know for the midterm. So backwards effects of left heart failure, once again, here's our little flow of blood through the circulation. So if we look at the left side of the heart, what's backwards, meaning against the arrows, the lungs are backwards. So if the left side of the heart is not working, fluid's going to get built up in the lungs. So all the backward effects of left heart failure are due to what we would say is pulmonary edema, meaning fluid in the lungs. The little memorization trip I use for this is left heart failure, lungs, fluid in the lungs. So left and lungs, they both begin with L. So keep that in mind, fluid in the lungs, but then there's specific vocab terms you need to know that are all different manifestations of that fluid in the lungs. So like different consequences. So one of them is orthopnea. So that is difficulty breathing when lying down. So like lying flat on your back. Dyspnea, that's just difficulty breathing in general. Proximal nocturnal dyspnea, well, this is just a special type of dyspnea, so difficulty breathing. And then nocturnal, that means night. So proximal nocturnal dyspnea, that's difficulty breathing while trying to sleep. So it's essentially disrupting your sleep. I always get questions of, oh, is that related to like sleep apnea? No, not necessarily. Sleep apnea is a separate, doesn't necessarily mean that you have like left heart failure or something like that, but just can have a similar presentation of difficulty sleeping at night. But in this case, this is specifically due to fluid in the lungs. Cough, of course, if you have fluid in your lungs, that's going to make you want to cough. And then crackles, meaning when you actually listen to the heart, you can hear it's crackly. I feel like we've all had like a chest cold before, and you can like almost feel that gunk in your lungs and like feel the crackliness. It's kind of like that. So once again, these are all backwards effects of left heart failure, all due to fluid in the lungs. So on the midterm, I'll remind you of this too. Draw this little picture to help you remember. And then if we see something that has to do with lungs, almost always that's going to be something about left heart failure, because lungs means fluid. Sorry, left heart failure means fluid in the lungs. Does that make sense? How are you feeling? Thumbs up? Yeah, nodding. Okay, cool. All right, so the backwards effects of right heart failure. Now, when we look at the right side of the heart, what is backwards, meaning against the arrow, going the opposite direction? That is the body. So if the right side of the heart's not working, essentially you're going to get fluid building up all throughout different organs or like different spaces in the periphery. So not the heart, not the lungs, pretty much anywhere else. So specifically where we tend to see this might be like fluid and swelling in the liver, which is called hepatomegaly. So that's in our large liver. Fluid or swelling in the spleen, that's splenomegaly. Jugular vein distension, so that is just like increased pressure in the jugular vein, and since the jugular vein is right in the neck, you can see that. Ascites, so that's fluid in the abdomen or in the peritoneal cavity. And then pitting edema, so that is fluid in the legs, swelling and fluid in the legs, and it's pitting because you can actually press on the tissue and like leave a little divot, because you can actually smoosh some of the fluid back into the circulation. So there's a lot of things, right? Hepatomegaly, splenomegaly, JVD, ascites, pitting edema, and they're all in different places in the body. Importantly, none of them are the lungs. So that's why if we see lungs, we think left heart failure. Anything else, we're going to think right heart failure. Fernanda, do you have a question?
So I have a question. So with like a pulmonary embolism, is edema always present, or can you get like a pulmonary embolism undetected with like no edema at all?
So a pulmonary embolism is different than heart failure. So a pulmonary embolism could be like a blood clot that forms in the pulmonary circulation, or usually it's a blood clot that forms somewhere else and then travels into the pulmonary circulation. So that is going to have a similar consequence where we're not getting adequate blood delivery to the lungs, but it's usually more like that's a blockage of blood is different than what we're seeing here, which is where like the blood just is kind of pooling and like it's congestion and it's not moving. So that's what's causing a lot of that fluid. In pulmonary edema, or sorry, in a pulmonary embolism, you could get fluid, but usually you are going to have more severe symptoms that are going to sort of like cause you to go to the hospital first. So you could see some edema maybe, but the more concerning part is just you are not getting you're not getting blood to the lungs. So you'll get like chest pain and trouble breathing and things like that as well. But you don't necessarily have just fluid. Does that make sense?
Yes, I was just asking because I know in the discussion I saw a few people say it was PE. So, and I
Mm,
know that, shortness of breath and chest pain is not specific to either pneumothorax or the
yeah,
pulmonary
for
embolism.
sure.
Like it could be very broad. Like that could be anything. So I guess that
Yes,
was just
yes,
my question since, well, I read like the case study and there was like no edema, no leg pain or any pain.
right.
That's why I was
Yes.
asking if, if it's like you will always get that edema and like pain in like a limb, or can it just go straight to the lung and like cause that like sharp pain and difficulty breathing and stuff?
Yeah. So something like a pulmonary embolism is going to be painful usually because anytime you have ischemia, so like lack of blood getting to a tissue, that's going to be painful. Um, so we would expect chest pain with a pulmonary embolism, where you wouldn't necessarily expect chest pain with something like heart failure. For the discussion, the patient has the pneumothorax. Some of the key things there was the lack of breath sounds on one side. That can happen with a pulmonary embolism. Um, but other things from the case that helped you figure out it was a pneumothorax is he had some other risk factors for developing pneumothorax. So he was tall, and he had Marfan syndrome, and those were both just increases likelihood of having a pneumothorax. But
Awesome.
good
Thank you.
questions. Yeah, yeah. Um, okay, so I know it's a lot. It's a lot of things. Um, for heart failure, sorry, for left heart failure here, once again, we're thinking backwards effects are more prevalent. So we're thinking edema, left heart failure, pulmonary edema, fluid in the lungs. So if we look at these words, orthopnea, dyspnea, paroxysmal nocturnal dyspnea, they all end in pnea. That ending means breathing. So that helps you remember those are all lung things. Cough, obviously, that's your lungs. And then crackles, you do have to remember that's like we're listening to the sound and we're hearing fluid in the lungs. And then these guys, hepato, that means liver, spleno, that means spleen, obviously. The jugular vein, that's in your neck. And then ascites, you just have to, I don't have a good trick for that one. You just have to remember that that is fluid in the abdomen. So it's not in the lungs, it's in the abdomen. I mean, it begins with an A, like abdomen, maybe that helps. Oftentimes when you see a picture of someone with ascites, they almost look pregnant, like they're so full of fluid in their abdomen. And then pitting edema, same thing. You just have to remember that the pitting we're talking about is in the legs. So that's swelling in the legs. I know a lot of things to remember, but hopefully given that framework that can help a little bit. Okay, so we're going to do a couple little check for understanding questions here. So just think about it for a second, don't say it. Which is a hallmark sign or symptom of left heart failure? Okay, so to think through these questions when you're on the midterm, here's how you should think about this. First, you're going to draw your picture of blood throughout the circulation. And we're talking about left heart failure. Usually, if we're thinking signs and symptoms of heart failure, we're thinking backward effects. So what is backwards from the left side of the heart? The lungs. Left heart failure, we're thinking fluid in the lungs. That's another way to ask this question is, which one is fluid in the lungs? Jugular vein, that's in your neck. That's not in your lungs. Pitting edema, that's your legs. Ascites, that's fluid in the abdomen. So proximal nocturnal dyspnea, trouble breathing. So that is our best answer. Does that make sense? how we kind of like reasoned our way through that. All right, let's do one more. There might have been two more. Which is a backward effect of right heart failure. Okay, so same thing. We're going to draw our picture. We're talking about right heart failure. So it is backwards from the right side of the heart. We're going the opposite direction. That is the body. So in other words, we are thinking swelling throughout the body. So peripheral edema. Fluid anywhere that's not the lungs is going to be the answer. So cyanosis. And this, I wanted to go over this one because this was on the practice sheet. So cyanosis is due to hypoxemia, which is low oxygen in the blood. That's like a lung problem, even though we are seeing that low oxygenation in like the fingertips and mucous membranes and stuff. The problem is actually in the lungs. So it's a lung thing. So we're talking about fluid elsewhere. This is lungs, so that's not it. Orthopnea, same thing. That is a fluid in the lungs. That's not what we're looking for. Jugular vein distension. That's the jugular vein in the neck. So we're talking about extra congestion and fluid in the neck. That's not the lungs. So that's going to be our answer. And then decreased urinary output, that would be something to do with the kidneys. In this case, that's decreased perfusion of the kidneys. So it would actually be a forward effect of left heart failure. So there is a question on the midterm like this where you have to, where it actually asks like specifically a backward effect of right or left heart failure. So you have to reason your way through this one, JVD. In this case, this is not the exact question, obviously. That would be cheating. Does that make sense? Have we got there? Okay. I got one more, I think. Nope, I don't. Just kidding. I have more, always. Then heart failure. Heart failure is the heart failing to do its job. The heart normally pumps blood. Heart failure, the heart is gotten weak. It cannot pump blood anymore. That is different than a myocardial infarction, which is what we usually think of as a heart attack. So think it's like an attack. It's fast. It's sudden onset. Heart failure is something usually that develops very slowly. So it takes a long time generally for someone to become or to develop heart failure. Someone who has had a heart attack might develop heart failure in the future because their heart has been damaged, but they are two separate disorders. So myocardial infarction, the name itself gives you a hint. Infarction is necrosis. So that's the bad type of cell death. And it is necrosis due to prolonged ischemia, meaning the heart is not getting its own blood supply for so long that part of the heart actually dies. So that is bad. This is essentially, it's a medical emergency. It is similar to angina, which is also ischemia to the heart, but it is not prolonged. It does not cause tissue death. So a myocardial infarction, it has the word right in there. Infarction meaning tissue has died. So a myocardial infarction is worse than angina. That being said, the signs or symptoms can be kind of similar between those two. They both have chest pain. The difference is with a myocardial infarction, the chest pain does not improve with rest or with medication. Someone who has stable angina, they can take a medicine and it usually will make them feel better. But someone who is having a myocardial infarction, the medicine, there's no medicine that you can take that just immediately makes you feel better. You need to go to the emergency room. Question, yeah, Fernanda.
Sorry, I do know that sometimes the symptoms for women are different than for men.
They are.
Is that something that we have to take in consideration for the midterm? Like I know if it's a woman in bigger chest, it might be more radiated towards the back. And also the left arm numbness and stuff like that. Do we have to kind of differentiate men and women symptoms or just broad overall heart attack symptoms?
Yeah, that's a good question and a good call out because yes, the symptoms are different for women and unfortunately you don't need to know that for the midterm. Should you know that? Yes, but you don't need to know it for the midterm. But you're right, sometimes the chest pain for women may not feel the same. Often sometimes it might get misdiagnosed as heartburn or nausea even. And yeah, it's interesting. It's not clear why necessarily the symptoms might be different for men or for women, but you're right, they are. What you guys need to know for the midterm is essentially this stuff right here. These are the main signs and symptoms that you should know that are specifically or more specifically associated with myocardial infarction. So chest pain, and you're right, it can be like radiating chest pain, but importantly, this part that the chest pain doesn't improve with rest or medication, that does tend to be similar for both sexes. Levine signs, that is fist to chest. So like because of the chest pain, you're like putting your hand over the pain over your chest. That is something you also do see with angina. Diaphoresis or sweating, and anxiety. So these are some of the big ones that are associated with myocardial infarction. This first one I would say is probably the most indicative of a myocardial infarction versus angina, is the chest pain that does not improve with rest or medication. And then like risk factors for developing myocardial infarction. So usually what happens in a myocardial infarction is you have occlusion of coronary arteries. So usually that is due to atherosclerosis within those arteries. So anything that increases the risk of atherosclerosis is going to increase the risk of developing a myocardial infarction. These are a lot of the same things as your discussion last week with that patient who had peripheral arterial disease. That's a type of atherosclerosis. So same idea, anything that makes it more likely that your arteries are going to get kind of like inflamed and then gunked up is going to increase the risk of any sort of artery disease, including coronary artery disease or a myocardial infarction. So age is one, just as you get older, the hardness of life, no, just the cumulative damage of being a human. Smoking has a lot of toxins and things that cause damage to the endothelium. And anything that is causing inflammation and damage to your vascular endothelium is going to increase the risk of atherosclerosis. Diabetes, specifically uncontrolled diabetes and hypertension, those also both can cause damage and inflammation to the vascular endothelium, which is why they increase the risk of atherosclerosis. And then, of course, high cholesterol or hyperlipidemia, because those atherosclerotic plaques are comprised in part of fat. If you have more fat in your blood, it increases the risk of developing atherosclerosis. So all of these things increase the risk of developing a myocardial infarction. There are other things too, but these are the ones that all make sense in the context of atherosclerosis. Okay, let's do a check for understanding question then. Okay, which patient is most at risk for a myocardial infarction? So I just said anything that increases the risk of atherosclerosis is going to increase the risk of myocardial infarction. So it's another way to ask this question. Who's most at risk for atherosclerosis? So what is atherosclerosis? It is inflammation of the vascular endothelium that causes those plaques that are mostly made of fat. So anything that increases vascular inflammation or causes damage, and or anything that increases lipid in the blood, fat in the blood, that's going to be our answer here. So best answer, I think this is also, yeah, it's the most straightforward one. It's D. Yeah, so the older people in general are going to be at higher risk. And then he has two risk factors, or this person, hypertension and smoking. The 35-year-old diabetes mellitus, is that a significant risk factor? Yes, but this person is older and has two risk factors, so that is worse. Does that make sense? We just kind of like added together the risk factors. Okay. A patient presents with crackles in the lungs. What cardiovascular disorder is the most likely? Think about it for a second. Okay, crackles in the lungs. So when we say crackles, that means when you listen to the lungs, they sound gunky. So that should make you think there is either like fluid or an infection. There's gunk, fluid in the lungs. None of these options are going to give us like a specific lung disorder. These all have to do something with the heart. So in other words, it's a heart disorder that is causing fluid buildup in the lungs. Remember, anytime we hear left heart failure, we should think fluid in the lungs. So the best answer here is left heart failure. That's a backward effect of left heart failure. I snuck that one here in the end. We did a review of both the heart things. And then we didn't really talk about this, but infective endocarditis is like an infection that is actually in the heart muscle itself. That usually happens to the heart valves, become the part of the heart that is infected. And usually you don't have bacteria in your blood. So generally someone who gets endocarditis, it's because bacteria has been introduced into their blood in some way. So that's usually, for example, like IV drug use, or dental procedures actually can, because you have a lot of bacteria already in your mouth. And then like you've got, if you get a tooth removed, there's a lot of bleeding happening when that goes on. So you can just like introduce some bacteria into your blood that way, but just an aside. It has nothing really to do with fluid in the lungs. Okay. And then I said we'd just go over really quickly some of the pulmonary disorders. You do need to know pneumothorax, but that's your discussion for this week. So I think that helps understand the pneumothorax. And the biggest thing to remember for that is it's, essentially a collapsed lung. And so classic sign of pneumothorax is lack of breath silence on one side. Different, very different than acute bronchitis. We've all had acute bronchitis, probably. This is essentially a chest cold or a chest infection. So bronchitis, like, your bronchioles. So acute bronchitis, inflammation and infection in the lungs. Signs and symptoms, just think of having a chest cold. So persistent cough, and a cough that you're like coughing up gunk, so sputum, and it's usually yellow or kind of green sputum. Once again, we've all had this. Chest congestion, so you just don't feel super great. You probably can't breathe easily. So dyspnea, tiredness, you can even have a fever, depending on where you are in the infection. So how do you treat acute bronchitis? So obviously, you can take antibiotics to try to treat the infection. Try to clear up some of that mucus, so to help cough up some of that sputum. So Mucinex, that's an expectorant. Expectorants are things that help with expectoration, which is just coughing up gunk, coughing up mucus. I always remember in Beauty and the Beast, that song about Gaston, there's a line that is, he's especially good at expectorating, meaning spitting. So that's how I remember that. He's especially good at expectorating. That's spitting up mucus. Gross. And then obviously cough suppressants. So usually when you take like a cough medicine, they probably have maybe both some sort of cough suppressant and an expectorant to help you get that stuff up. So that is different than asthma. So I think because asthma, like you get like an attack of asthma, so it is acute when it happens, that there can be some difference here. But bronchitis is like an illness, whereas asthma it's almost like an allergy. So it's something that comes on quickly, but then you can treat it. So we tend to think that this is what we say reversible airflow obstruction, meaning the airway can become constricted and then it can open back up again. That's also different than something like COPD or chronic obstructive pulmonary disease. And COPD, you have, it's not reversible. So once those changes tend to be progressive, so they just keep getting worse with time. But usually in someone who has asthma, once again, you can think of this essentially as like almost kind of similar to an allergy. So something, it might be caused by allergies. So something happens that causes the airway to become inflamed, and then that inflamed airway is going to constrict. And then obviously that it's harder to breathe out of that little tube than to breathe out of the normal airway. So this is usually just due to like chemical mediators within the airway. So the nice thing is that means you can take medicines that just counteract those effects and open the airways back up. So treatments for asthma are things like, so when you see someone take an inhaler, usually what those inhalers are they are bronchodilators, meaning they are medicines that just help the airways relax. And then some patients who have asthma may also be on inhaled steroids, and the steroids can try to just calm down the inflammation overall, and kind of those are kind of like a preventative step. But if someone is like currently having an asthma attack, usually the inhaler has a bronchodilator in it as opposed to a steroid, because the bronchodilators are faster acting. once again, the key thing to remember with asthma is it is reversible. So in my mind, that makes sense to me because someone who has asthma, they take that inhaler and then they feel better like much more quickly than, for example, like if you have acute bronchitis, to go back to the previous one, and you're having difficulty breathing, you can't just like take an inhaler and feel better necessarily. So Tyra, do you have a question?
So if someone's going like into respiratory failure, can that lead them into like heart failure then?
Yes. So there's a special type of heart failure that's caused by essentially lung problems. That's called cor pulmonale. Usually we think of that as someone who has like a chronic lung condition like COPD, chronic obstructive pulmonary disease, which over time could lead to right heart failure. That's like one of the big complications of COPD. And sort of like an emergent situation. So if someone has like acute respiratory disorder, that can also cause sort of like acute heart failure as you have like multiple organs shutting down. But that's kind of a different universe, I feel like, than some of the stuff that we're talking about, which are more like chronic disorders. That's like critical care. Things are going wrong, things are going bad, and all the disorders are going bad. We'll talk a little bit about some of that stuff in module 8, which is the module about death and all critical care. You just end on like, all right, that's depressing.
All right, thank you.
Okay. Yeah. Okay, I think I have one question here. Yes. Which is most likely to be treated with an expectorant? Think about it for a second. Okay, so expectorants, those help with expectoration, which is coughing up phlegm, spitting, coughing up sputum. So in other words, which one has a sign or symptom that has to do with coughing up sputum? And that would be, bronchitis, or I should say acute bronchitis would be a better answer there. Asthma, once again, we usually treat that with inhalers or inhaled bronchodilators. And then COPD, that's going to be treated with a variety of different like chronic medicines. And a pneumothorax, that's usually something you have to get treatment within the hospital for. So an expectorant, that's something you can buy over the counter. You can't like over the counter treat your pneumothorax. Okay. That's all the stuff I had for module 3. Do you have any other module 3 related questions you want me to go over? Okay, cool. Let me see. I made mostly slides for module 3. We're going to skip around a little bit. Yeah. So for module 1, I do think I find module 1 to be a little bit more straightforward. It's a little bit more like vocab. So it's just kind of memorizing some of that vocab. I think where some of that gets confusing is with all those different types of cellular adaptations. And actually, let me back up my slide with 2 words on it. It's really great. So remember, cellular adaptations, these are all the different ways that cells respond due to injury. So we learned about like hypertrophy and atrophy. So those are like opposites. So hypertrophy is cells get larger in size, atrophy, they get smaller in size. And then we learned about hyperplasia, which is more cells. And then metaplasia, which is a cell type changes to a different cell type. Dysplasia, the cells are kind of funky. They're abnormally, have abnormal morphology. And then neoplasia, which is essentially cancer. So these are all different things that cells can do in response to an injury. And some of these things are as sort of precursors or the etiology for how different diseases or disorders occur. Actually, and I meant to make a slide about this, but I didn't have time. So we're just going to talk about neoplasia really quick. So neoplasia is essentially another word for cancer. And cancer is when cells are growing and dividing out of control. So I'm sure you remember, I hope you remember from biology, you learned about the cell cycle. So it's like the life cycle of a cell. So a cancerous cell or a neoplasic cell is just going through the cell cycle really quickly. There are essentially two main things that can contribute to a cell becoming cancerous. So I like to think of there's like gas and brakes. So a cell can step on the gas. It can go through the cell cycle more quickly. So that would be something called an oncogene, which this is beyond the scope of what we need to know for this class. But or you can have things called tumor suppressors. So these are things that usually normally would stop a cell from dividing. Or these are things that cause the cell to die by apoptosis. So for cancer, they can do both of those things. They can speed up and they can also essentially like cut the brakes. So you can think that something like apoptosis, which is healthy cell death, cells that are cancerous tend to not go through apoptosis as much because they're not dying. They're living longer than they should. So we talked about apoptosis and necrosis in this class. And so this is sort of like a connection between two of these concepts. So often neoplastic cells or cancer tend to like evade apoptosis, or they're kind of like not dying when they should. So we can say, how about, let's say, ignore normal signals to.
I have like a random silly question, but like, why is it bad for cells to live longer?
Right. No, that's a great question. And all different cells in your body live different and make lengths of time. Mostly the reason why it's bad for a cell to live longer than it should normally is because it could become cancerous. So the longer a cell is around, the more mutations it is going to accumulate. That's just true for all of your cells. And so that's sort of why we have like a natural turnover, because it's like, okay, let's get rid of this one. Let's start with a fresh crop of cells that don't have as many mutations. So a cell that's just around a long time is more likely to accumulate more mutations and then more likely to, if it divides, pass them.
Okay, makes sense.
Yeah. No, it's a good question. Also, normally your cells, for me, I feel like your skin is an easy way to understand this. If you get a sunburn, like a really bad sunburn, you have damaged your skin cells. So that burn that you can see is from significantly damaging them. The sun is UV radiation that is literally causing DNA damage to your skin cells. And then if you get a sunburn so bad that your skin starts peeling, that is because of apoptosis. Those cells have said, we are so damaged, we're just going to get out of here because we don't want to become cancer. But if that doesn't happen, if some of those cells don't die, but they got all those mutations, that's bad, right? Because now those cells can just go on and become cancerous. So apoptosis can be like a normal, healthy thing. And since it's a normal, healthy thing, cancer is not normal and healthy. Cancers sometimes avoid apoptosis. So they essentially won't die. Does that make sense? Great. So that was neoplasia. I wanted to go over that one. And then one of the other types of cellular adaptations, metaplasia. So this is when a cell type switches to a different cell type. So the way I remember this is metaplasia, like metamorphosis. So metamorphosis, a caterpillar turns into a butterfly. So they're turning into something else. There are a couple classic examples here, but the one we talk about a lot is in gastroesophageal reflux disease, or GERD, which is someone who has like chronic heartburn. So that is stomach acid from the stomach bubbling up into your esophagus. If you've ever had heartburn, you know it's painful. It's because your esophagus cells are not equipped to deal with that stomach acid, whereas the stomach acid in your stomach doesn't hurt because your stomach cells are fine with it. They have adaptations, or they've like evolved to not care about the stomach acid, but your esophagus doesn't have that. So if you have chronic acid reflux, what happens eventually is some of those esophagus cells might actually go through metaplasia and become a hardier type of cell to try to like adapt essentially to this chronic exposure to stomach acid. The downside of metaplasia is it increases the risk of cancer in the future. So metaplasia itself is not cancer, but it increases potentially the risk of developing cancer. And the reason for that is cells, when they undergo metaplasia, that's like a pretty drastic cellular adaptation. And to do that, I like to think it's the cell has kind of taken some of the safeguards away that should prevent it from becoming cancer. So it's like just made it a little bit less cautious. Yeah, Fernanda.
Sorry, so does Barrett's esophagus basically mean like a precancerous stage?
Yes, yes. So if you have Barrett's esophagus, oftentimes you'll probably have to go in and get like an endoscopy or just check on it every couple of years because they just want to make sure like it's not becoming cancer. They're kind of keeping an eye on it.
Got it. Thank you.
Yeah, good question. So once again, why does that happen? It's because of repeated exposure to that stomach acid, so repeated exposure to stressors or toxins. So if you had heartburn one time, you probably are not going to develop Barrett's esophagus because this is like a pretty intense thing that those esophagus cells have had to do. But someone who's having repeated acid reflux, because the cells are constantly getting bombarded with that stomach acid, that's what's going to cause metaplasia. So it's usually repeated exposure to stress or toxins is what tends to cause metaplasia. Yeah. And then dysplasia is the other cellular adaptation. We'll write this down just to have it. Dysplasia. This can also predispose cells to becoming cancerous. So, but once again, these are not cancerous, but not cancer itself. The classic example here is when you get a pap smear, is looking for cervical dysplasia. And if you've ever had an abnormal pap smear, then you know that they will tell you like, let's keep an eye on it, come back, let's keep checking. So it's not like, oh, you have cervical cancer. It's just like, let's keep an eye on this. If they're really concerned, maybe they'll remove part of it just to try to, get ahead of it potentially becoming cancer. But that's essentially why you get pap smears, is to check for those cells if they do look abnormal. And then if they do, then you are probably going to get more frequent pap smears just to keep an eye on it because they're sort of like precancerous, but not cancer yet. Is that all my module 1 stuff? I'm trying to think what are other tricky things for module 1. Oh. Usually you guys tend to do great on the infectious disease stuff because you remember a lot of this from micro. So this is a place, once again, I think, prioritize your time. This, I think a lot of the infectious disease things are easier. Some things to remember, once again, I think this is easy. Yeah. So MRSA, which is a specific type of antibiotic resistant bacteria. MRSA is also just medically, like within the healthcare system, really important because it's a common hospital acquired bacteria. So just important to remember that the SA in MRSA stands for S. aureus. So that's an example. Some other ones. Oh man, this is a spelling test. Clostridium. Yes, I did it. When I took microbiology way back in the day, my professor made spelling count on the test. And I was just like, why? This is so mean. I didn't do well on that part, on the spelling part. It's just like, this is so annoying. Anyway, So Clostridium tetani, that is the bacterium that it makes a toxin or releases tetanus toxin. Tetanus causes muscle paralysis and like rigidity. Oftentimes it presents with lockjaw, so it's like paralysis in the jaw. That is an example, another example of a bacterial, well, in this case, the toxin, but still a bacterial infectious disease. Oh no. Yeah. So Clostridium botulinum that releases the botulism toxin, which causes botulism. Botulism toxin, that is also the same thing as Botox. And what does Botox do? It treats wrinkles. And how does that do that? By paralyzing those muscles. You are all younger than me. I don't know if any of you had Botox, but it does. It just like, I don't have any right now, but I've gotten it before. And it is weird. It just like all of a sudden you can't move your muscles up there and you're like, oh, that's creepy. So Botox, just like botulism toxin, causes muscle paralysis and weakness, along with other signs and symptoms. But that's also one that is medically important because we have this whole medicine that is botulism toxin. But I always like to go for those two because those two are actually not on the learning guides that I made. They're on there because I added them, but they're not on the learning guide that's on Canvas, and that always bothers me because they're on the midterm. And I think all the things you need to know on the midterm should be on the learning guides, but that's just me. And then I think there's one, good to know that varicella virus causes chickenpox. And then later in life, if you have been exposed to varicella virus and you had chickenpox, then later in life that can cause shingles. That's the same virus, but it causes essentially two like related but different diseases. I think those are all the ones I can remember off the top of my head from Module 1. Any Module 1 questions? I feel like that's the one that's the most vocab-y. So in my mind, vocab's a little easier because you can just like memorize it. Whereas signs and symptoms, it's like you have to know the vocab and then apply it. So I think those questions are a little trickier. Okay, Module 2. Nope, we're going backwards. Okay, actually I'm gonna add a slide before we get here. Anemias. There are so many different anemias, right? And they all have similar signs and symptoms. So remember, anemia across the board means we have like a deficiency or defective red blood cells. So red blood cells deliver oxygen. So all anemias are going to cause hypoxia, meaning low oxygen delivery to tissues, little different, but related to hypoxemia. So that means that all anemias have signs and symptoms that are related to hypoxia. So those are things like pallor, tiredness, weakness, fatigue. Those are the same words. Tachycardia, fast heart rate, dyspnea, shortness of breath. These things, all of these similar signs and symptoms are not very helpful for helping you distinguish different types of anemias because they're the same for all anemias. So these signs or symptoms can point to anemia generally, but not specific type of anemia. Instead, you should also know some of the like specific signs and symptoms. Or I should say the signs and symptoms, this S+S means signs and symptoms. For iron deficiency anemia, the lack of iron is going to sort of not related to the hypoxia. Just the lack of iron is going to cause other problems because iron is used for other things in your body. So that includes things like pica, which is wanting to eat non-food items like ice, dirt, things like that. Changes to hair and nails, hair loss. And then there's also some sort of changes to the mouth and tongue. Yeah. Perfect. That's for iron deficiency anemia. So these are the ones you should know. So if you see a patient and they have pica, that should make you think iron deficiency anemia because pica is only associated with iron deficiency anemia. It's not associated with the other anemias, if we're talking about anemias. If you see, we're talking about hemolytic anemias, like hemolytic disease of the newborn, we think jaundice. If we are thinking anemia of acute blood loss, because you are losing so much blood, you have hypotension, so low blood pressure. And then that hypotension can also cause some other issues like urinary retention and dilutional decrease hematocrit. Meaning because so much fluid has been lost from the body is trying to hold on to all the fluid that they possibly can. So the person might be really thirsty and not going to the bathroom to hold on to fluid. And because the body's holding on to the fluid, that actually will dilute out the number of red blood cells they have because the body can't make enough red blood cells quickly enough to make up for the fact that they're holding on to extra fluid. What else is there? Sickle cell anemia. Classic one there is vaso-occlusive crisis, which are the little sickle cells make almost like a clot. It's not technically a clot, but same idea. And that causes ischemia and pain. So those are the specific ones that you should know because once again, those point to specific types of anemias. Those are sort of more helpful than, you should also know the general ones, but they're going to be more indicative of the specific type of anemia. Okay. So for iron deficiency anemia, this is also important to know. It is the most common type of anemia worldwide, is iron deficiency anemia. And once again, it's more common in women who are menstruating than men. So women in their childbearing years. You also can have iron deficiency anemia caused by lack of dietary iron. So someone who's a vegetarian is going to be at higher risk for developing iron deficiency anemia because you can get a lot of iron from meat, but you can also get it from leafy greens and other places. It's not just meat. But so we already talked about some of the characteristic signs and symptoms: hair changes, nail changes, wanting to eat non-food items. So this is another good thing to know here, how to treat it. So if you have iron deficiency, how are you going to treat that? By giving iron, right? That seems so straightforward. So the most effective treatment is actually IV iron. So just putting iron directly into the blood. that requires that you have to go in to get an infusion. So it's inconvenient for the patient. I've also heard it's painful, kind of, that the iron itself doesn't feel great going in. So usually that is not the first place that you will start unless the iron deficiency is more acute or more severe. Usually someone might start with just iron pills. So if you go and buy iron pills at the store, it might say ferrous sulfate. Maybe you remember from chemistry that the word ferrous means iron. So that's just the chemical name for iron is ferrous. Ferrous sulfate is like the actual mineral that you're taking. So it's not pure iron. It's iron. It's like an iron salt. It's easier to digest. And then your body actually needs vitamin C in order to absorb iron from your gut. So that's another big one. So not just the iron pills, but also maybe some additional vitamin C that can help absorb that iron and get it into the bloodstream. There is a question about treatment for iron deficiency anemia. And those are the 3 things you should know: IV iron, oral ferrous sulfate, and vitamin C. Beautiful. Hodgkin's lymphoma. So in terms of the blood cancers, oh yeah, question.
Sorry, I just have a question. Just to
Okay,
clarify, anemias can be reversible, correct? Like once,
yes,
you know, it
yes,
meets that, because I know I was anemic when I was little, but
yes,
I mean, then I didn't know, and I was like, okay, but now I know.
yeah.
So, is there any type that's like so severe that is not reversible, or is it usually just, you know, you take the supplements and you're fine?
But yeah, good question. Most types of anemias can be treated, so they could be reversible if you can treat the underlying cause. So like the underlying cause of iron deficiency anemia is lack of iron. So if you can replenish iron, then that gets better. Or so, for example, like this could be another cause of iron deficiency anemia, like if you have really heavy periods. That could also be considered like an anemia of chronic blood loss because you're just losing a lot of blood more than you can replenish. So if in that case, a patient might go on like birth control or pills or something to make their periods lighter, and then that would decrease the blood loss every month, and then that would help essentially treat the cause of the anemia. Types of anemias that you cannot just sort of like reverse or cure are things like sickle cell anemia. So that's a genetic disorder. So interestingly, there are some interesting studies coming out right now of like genetic treatments. So like gene therapy to help people who have sickle cell anemia, but that's like very much just starting out. So for the most part, sickle cell anemia is something that someone has for life. And obviously that's much more severe.
Awesome. Thank you. That's really cool, though. I didn't know that they were working on that. That's
Yeah,
actually really,
yeah,
really nice.
yeah. It's fascinating. There was a story about like this boy who got treatment because sickle cell anemia can really, I mean, it's really painful and it takes a
Yeah.
lot out of your life. So it's exciting that we're seeing some treatments for it.
Yes. I work at a research hospital and I donate blood all the time just for those type of
Oh,
trials. And I know one
yeah,
of them was for sickle cell. I mean, they were obviously just comparing like the healthy to like that and like trying to make something, but I'm like, I don't know, I just donated. I don't know what actually
yeah.
went on in the
Like,
lab, but I thought that's pretty cool.
yeah, it's like anything you can do to help. Why not?
And I
It's
got
great.
$50 for it, so that's fine.
Oh, hey, see, that's like a triple win. um, okay, so also in module 2, there's blood cancers. There are a bajillion blood cancers. You guys only need to know 4. So it was CLL, chronic lymphoblastic leukemia. Sorry, chronic, yeah, ALL, acute lymphocytic leukemia, Hodgkin's lymphoma, and non-Hodgkin's lymphoma. In module 2, there is a slide. I'll find it in a second that like summarizes some of the key things you need to know about those. For Hodgkin's lymphoma, it's a lymphoma. So oma means tumor, lymph like lymph nodes. So lymphomas are cancers that are white blood cells in the lymph nodes. Specifically, Hodgkin lymphoma is a proliferation of B lymphocytes, so B cells. And you see these very specific types of funky B cells, and this is what characterizes Hodgkin's lymphoma. So this is looking under a microscope, and this dark thing here, that's a normal lymphocyte, a normal B cell. And then this crazy looking thing over here, that is an abnormal B cell. This is called a Reed-Sternberg cell because it has 2 nuclei in it. So it's got, it sort of looks like owl eyes, they say. So if you see something about Reed-Sternberg cells, immediately that is Hodgkin's lymphoma. That is like the diagnostic criteria for someone to have Hodgkin's lymphoma. Some risk factors here. All the types of blood cancers, all the ones we're learning about, are more common in males. Hodgkin's lymphoma also has like a bimodal distribution, so it's more common in young adults and then also in the elderly. Most cancers are more common in the elderly. And interesting, Epstein-Barr virus, which is the virus that causes mononucleosis, also increases the risk, but potentially, of Hodgkin's lymphoma. Epstein-Barr virus increases the risk of all sorts of things. It's kind of scary. There was some big study like 2 years ago saying it might be the cause of multiple sclerosis. And then there was another study I just saw this week that it might be the cause of, what was it? It was another like autoimmune, lupus, maybe they think might be related to Epstein-Barr virus. So it's like, and like 90% of people have had Epstein. We probably all have had Epstein-Barr virus and you don't even know. So, scary. And here, let me find that slide really quick. So in the module 2 slides, there it is, this guy. So definitely know this overall. These are sort of like the most key things. So the type of cell that is affected, so they're all white blood cells, but what type of white blood cell? So for ALL, it's T cells or B cells. For CLL, it's B cells. Hodgkin's lymphoma, it's also B cells. Non-Hodgkin's, it's B, T, or NK cells. And then the most common age. So I feel like as you get older, cancer gets more common, so that always is kind of there and always makes sense. ALL is more common in children, and it is acute, it's sudden onset, and it makes sense that a cancer that is sudden onset is more common in children as opposed to slow onset, because kids haven't been around long enough to develop a slow onset cancer, usually. And then Hodgkin's lymphoma has that weird bimodal distribution, so young adults and then again in elderly. Okay, yeah.
This is all in the module 2 slides, correct?
Yes, yeah, that was from the module 2 slides.
Awesome, just clarifying. Thank you.
Yeah, there's another good little summary table in there about hypersensitivities too. Worth refreshing. We'll just copy that over too. Okay, and then Virchow's triad and blood clots. So Virchow's triad is things that may increase the risk of developing blood clots. Oh, sorry, do you have another question? So usually we talk about this oftentimes in the context of a deep vein thrombosis or a DVT. So if you have ever had surgery or something, they probably did a lot of things to prevent you from developing a deep vein thrombosis. And these are all essentially Virchow's triad things. So there's 3 parts of the triad. The 3 things are hypercoagulability, so increased risk of just forming a blood clot. So you can think like thick blood or sticky blood. Usually things that fall under hypercoagulability are genetic conditions. Like one of them is called factor V Leiden. That's actually fairly common. Or like birth control pills. Some types of birth control pills can make your blood just a little more sticky. Or pregnancy. Pregnancy is actually a huge one. If you think about it, birth, you lose a lot of blood. So your body's preparing for that by making your blood clot more easily. But then obviously that can also increase the risk of blood clots. that's thing number one is hypercoagulability. The second thing is stasis of blood flow. So just like blood pooling. Anytime blood is just sitting and pooling in your veins, it makes it more likely to form a clot. That's especially true in the legs because it's sort of hardest for the blood in your legs to get back up to your heart. So that's why some people might wear compression socks, especially on like long flights, to just kind of help the blood not sit around in your legs so much. Yeah, question.
Sorry, I have so many questions. So can
No, of course.
preeclampsia lead to DVT in pregnancy or not really?
That is a good question.
Because I know it's like a lot of edema and like, you know, like
Yes,
the vessels kind of constricting a bit more.
I don't know if preeclampsia increases your risk of DVT more so than just like being pregnant on its own. Because just being pregnant increases your risk. I don't know enough about the etiology of preeclampsia to wager a guess.
No worries. I was just kind of like connecting,
it's a good
like,
question.
oh, like, you know, like it's more edema, it's, you know, constricted. So like I was wondering like maybe there's like a higher possibility of like developing that blood clot. But yeah, I don't know either. I just know because my auntie had preeclampsia, so I remember one time they had to do the DVT, the ultrasound. So I'm like, oh, like does that correlate or was just like that just like an unlucky situation that happened?
Yeah, no, that's a good question. I will have to look that up and find out.
Awesome. Thank you.
And then so the third risk factor is endothelial damage or injury. So think, you know, the normal function of your blood clotting is if there is an injury, the blood clots to stop bleeding, right? So if you have injury or damage to your blood vessels, that's going to activate blood clotting. That's normally what should happen, right? But some of that damage can be caused by things that aren't actually causing bleeding. So anything that sort of causes inflammation or damage to blood vessels just increases the risk of blood clots. So that can be actual like trauma or surgery, but it could also be things like some of the things we talked about before, like high blood pressure, uncontrolled hyperglycemia, and diabetes mellitus. All of that can increase the risk and cause endothelial damage. So these three things together are sort of the three main risk factors for forming blood clots and for potentially developing a deep vein thrombosis or a DVT, which is a blood clot in the deep veins, usually in the legs. What else from? Good. Oh, well, we're here. Any other module 2 questions? Sorry, this slide made me remind myself of this. In module 3, when we're talking about things like myocardial infarction or angina, which are both essentially ischemic heart disease, so the heart's not getting enough blood, one of the treatments for that can be a coronary artery bypass graft, which you might have heard that called like a triple bypass or a double bypass or something. So that's essentially, if you imagine there's a blockage in this coronary artery that's caused by an atherosclerotic plaque, so the gunk that forms in the arteries. A bypass is essentially taking a different vessel and surgically attaching it around that blockage. So if there's a blockage here, we'll just take a vessel and go bloop and sort of like go around that blockage. So the blockage is still there, but the idea is that now there's just another avenue for the blood to go that doesn't have a blockage. So now it's sort of like, it doesn't matter if there's a blockage there because we have a detour kind of that goes around the problem. So if you hear someone say like a triple bypass, it means that they had to have 3 little vessel bypass grafts done. And usually they'll do them like all at the same time. Where do those vessels come from? So they come from your own body. So usually they can come from veins in the leg. That is partly because they're easier to access. So they'll just take a little piece of the vein out of the leg and sort of then just stitch it back up so the leg vein is fine. And then they'll take that little piece from the patient's own body and then use it to make a graft that goes around that blockage. So crazy. Okay. You guys want to do all these check for understanding question? Let's do it, and then we'll be done.
Yes.
Okay. What kind of cellular adaptation can occur if a cell is exposed frequently to a toxin, chemical, or stressor? Yeah, so the classic example here is Barrett's esophagus, which is due to repeated exposure to stomach acid, and that is an example of metaplasia. Yeah, good. What are the 3 parts of Virchow's triad? We just went through this one. I know this is harder to say. So we have hypercoagulable state, venous stasis or like blood pooling, and then endothelial injury, like damage to the blood vessels. Edema is caused by backwards or forwards effects of heart failure. So edema is backwards. And the way I remember that is think about like a beaver dam. That's like the heart failure. And then what happens with a beaver dam? You get all that water pooling, backwards behind the flow of the river. So downstream from the beaver dam, it's just going to be a little trickle. You have decreased perfusion. But backwards from the beaver dam, upstream, it's just all fluid, all lots of swelling. So same idea with heart failure, because the heart's not pumping enough. Forward, we just have a little trickle. Backwards, we get all that fluid buildup. So it's edema. Oh, I'm glad we talked about this one. What is a CABG, or that's a coronary artery bypass graft, used to treat? So the name gives it a hint, coronary artery. So we're talking about heart stuff. And the coronary artery, that's the artery that supplies the heart. So a CABG is used to treat myocardial infarction or angina. Or I guess we could also say coronary artery disease. Those are subtypes of, too many terms all for the same thing. Okay, what are some signs and symptoms that are characteristic of iron deficiency anemia, but not all anemias?
Pica?
Yep, that's our classic one. The eating non-food stuff. And then some of the other ones. Yeah, definitely. Yeah, iron deficiency, for sure. The iron deficiency can also cause changes in your hair and nails. So like hair loss, brittle hair, brittle nails, those spoon-shaped nails, things like that are also commonly associated with iron deficiency anemia. Okay, which cardiovascular condition improves with rest and or medication? So it's like chest pain that improves with rest.
Myocardial infarction?
So in this case, because it gets better with rest, it's not going to be myocardial infarction. Yeah, it's going to be angina. Yes, that's like the key difference is if it gets better with rest, then it's not a heart attack or it's not an MI. It's probably angina. I don't like this question. But sure. What are Reed-Sternberg cells? Or like what disease are they associated with?
Hodgkin's lymphoma.
Good. Hodgkin's lymphoma, and specifically they are abnormal B cells or B lymphocytes. Oh, and then this one, what are some risk factors for infective endocarditis? So that's an infection of the heart tissue itself.
IV usage.
IV drug use, that's the big one. Pretty much anything that like introduces bacteria into the blood. So other things can be recent dental procedures.
Yeah.
Also heart valve replacement, if you've had like a replaced heart valve, that can also increase the risk.
Would this kind of be considered hospital acquired or not really? Because it could be like outside of that too.
Not necessarily. I mean, someone who like just had a heart valve replaced, if they then had infective endocarditis right after that, then yes, that would be considered hospital acquired probably. But otherwise, no. So usually it's someone who's like an IV drug user. So someone who's like shooting things. And since it's a dental procedure, that's not technically the hospital. So that's a good question. And then there are the answers. Cool. Okay. Any other questions? All right, so before I let you guys go, as just a reminder for everyone, helpful links for Patho website has all these helpful links. And if you go to the midterm exam study resources, it'll take you to all these helpful things to study for the midterm. So definitely do these things, do different things, don't just do one thing. If I had to recommend what you should do if you are prioritizing your time, the flashcards, which I gave you in class last week in module 2. If you didn't get them, there is a link to the flashcards. Definitely review those. And then there's also the practice questions in Wayground. This is pretty long, so if you want to do the one module at a time to help break it up, that's not a bad idea. Between those two things, that's pretty good if you can do both of those and feel confident. But I don't recommend you just do the Wayground like 5 times, because then I'm worried you will just memorize the questions, and then the wording is different on the midterm, and then it can get complicated. So, okay, any questions before we go? Okay, awesome. Well, thank you all for joining. And yeah, if you have any questions while you're studying, just reach out, send me an email.
Thank you.
Thank you.
Okay.
Thank you.
Bye.